Season 3.0. We are going strong, and we welcome you to join us in our journey of learning, in our journey of sharing, in our journey of understanding the joys of managing diabetes. Now, when we use the word joy, suddenly an emotion creeps in, a joyful, a happy, a cheerful emotion. And that's what emotions are meant to be. They are meant to be joyful, they are meant to be happy, they are meant to be cheerful. Emotions are part and parcel of what we are as human beings. But then the challenge with the emotions is that they keep on changing. Just now we were joyful. Suddenly, when we realize, oh, we have to sit in this webinar now for the next 40 minutes, that joy may change to something else. That something else is going to be more joy. We're going to become more joyful. And now that I think of the word joy or the word pleasant, that reminds me of our first speaker for today, Dr. Manohar. The word Manohar in Hindi means pleasant, someone who captures your man or your heart. So warm welcome, Dr. Manohar.
Namaste, sir. Thanks for this joyous introduction.
And this will work, Dr. Manohar, whenever you are kind of in the losing on the losing side of a battle with your better half. Then you just use the Manohar ones. Dr. Manohar is a lead consultant physician and diabetologist at Bangalore, and he's a triple FRCP, which is a feat that very few of our colleagues are able to achieve. He's also a fellow of the American College of Physicians, and as you will realize over the next half an hour or so, he's someone who truly believes, who truly walks the talk when it comes to person-centered care. So warm welcome again, sir.
Thank you, sir. Thanks very much.
We all worship Saraswati, we all worship education, and a warm welcome to Dr. Pooja Prakash Prabhu. Warm welcome, madam. Dr. Pooja is Assistant Professor in the Department of Nephrology at Ramaiah Medical College, Bangalore. Warm welcome, ma'am.
Thank you, sir.
And to complete our trio for today, we have Dr. Anusha Buchade. Dr. Anusha is a cardiologist who is currently working as Senior Interventional Cardiologist, again in Bangalore. So warm welcome, madam.
Thank you, sir.
Our talk for today is emotions, how we walk the talk, how we navigate the various emotions that we see when we are treating diabetes. So let's talk about emotions first, and let's see what kind of challenges we face. So Dr. Manohar, in your OPD, do you always have happy kind of patients who are affable, accepting, agreeable, or do you have other kind of patients?
I think I always say that psyche and the soma cannot be separated, isn't it? If someone has come to you with some somatic problem, it will be reflected on their psyche, and if there is something with the psyche problem, some somatic symptoms are always there, like aches, pains, tiredness, which is common. The biggest problem with our profession is we see always unhappy faces. As expected, very, very rarely someone who is doing very well come to us, isn't it? So after the discharge, and if they're still doing very well, they are the only happy people, I feel. Otherwise, most of them naturally have the concerns, and it is up to us to make them understand, make comfortable, and also keep this psyche in mind and treat them. So that is the challenge. That's why I always think that why was doctor's handwriting very horrible? All of us, to begin with, may not be having such a horrible handwriting, isn't it? But I always tell to my students, nowadays we are all into EMR, so the headache is less. Even the signature is signed by the EMR now. We keep listening to sorrows, worries, and miseries. So I always tell my students, like, let's say I'll ask you to write a love letter. We write it very nicely and beautifully. But from morning to evening, if you're listening to sorrows, naturally handwriting and even our mindset goes down. So it is on the both sides for the patients and also the caregivers, and the patients' caregiver burnout. I think all these three things, and of course the people who are working with us. Unlike a hotel check-in, we are all in a relaxed mode when we are traveling, and something goes wrong, we still have mind to accommodate it. When we are already in pain and irritation, even something goes wrong by a minute, by a word, then we blast out, isn't it? So this is the special situation which all the doctors are facing, which we need to deal with it.
That's true, and all of us face this challenge of diabetes distress, especially insulin distress. So the moment you write insulin, you prescribe, patients begin arguing, they get upset. The worst is when they come back, they are feeling healthy, they are feeling better. But the only fault they will find is with your insulin prescription. The rest of it is okay. They will argue with it. But Dr. Anusha, is this a matter of the mind or is it a matter of the heart? When someone comes to my OPD, she is angry, argumentative, or perhaps she is anxious, afraid. Is that fear or that anger, is it coming from the heart or the brain? And do you encounter such patients in cardiology as well?
Yes, sir. I think it's their it's from their brain or probably from their mind, if I have to say it, put it more clearly. I see a lot of patients, especially when it comes to MI, myocardial infarction, not a person who comes with chest pain. When MI comes, it always gives an unpleasant surprise, and most patients are in denial. They always think, I was perfect, I didn't have any problem, my parents didn't have any problem, my friends didn't have any problem. How did I get it? And they eventually become so argumentative, so questioning. They just and they have so much of self doubt. They want to confirm each and every action and validation from their doctor. Sometimes it becomes a task for us to keep answering all the queries one by one. I've seen this many in almost all my young patients, especially older patients. Somehow they, I think, accept their illness more readily than younger patients. They dispute it a lot. So yes, I come across these patients a lot, and most of the times it is even more difficult when it happens to a patient with no risk factors. There's nothing to tell them justify their illness. So in such a case, it becomes very difficult for us to make them accept their illness. And once they accept, then follows the adherence with medications, lifestyle, and all that.
That's true. So both in the diabetes clinic and in the cardiology OPD or ICU, we find these challenges, emotional challenges, and they might act, first of all, like Dr. Manohar said, they might act as a bad influence on the physician's health as well. We also become depressed talking to depressed people. And the second is, like Dr. Nusha says, it actually might end up harming the patient because they delay their therapy. They might have come to you in the golden hour, but they will keep on questioning, counter questioning so much that that window of opportunity will go. Dr. Pooja, usually the sickest patients, the most difficult patients are in nephrology. So is there a concept of dialysis distress? The moment you prescribe dialysis or you begin, patient goes into distress or denial and also decides to find another doctor.
Yes, sir. So very well placed. Actually, I can commend you that you had all D words in your sentences. So I keep telling that the D word is what they don't want to listen to, the dialysis. So everything else is okay with them, but that particular thing is what they are worried about because they feel that's the end of the story. So actually, I feel that's the beginning of the things because as long as they have been CKD for some time, and it's only probably in India where we delay the initiation of dialysis. It's almost in the Western countries, once the GFR comes below 15, it's like straight away they are into the dialysis thing. But in our country, we follow some symptom management till the uremic complaint sets in, or a few things which patient priority, patient preferences, sometimes family preferences, patient sometimes has no choice. So the delay in the initiation of dialysis also causes some amount of distress, some amount of protein energy wasting, frailty. Those things set in even before the dialysis as such is started. So that's why they feel, oh, your patient is very weak. Can the patient undergo dialysis? That will be the first thing. They wouldn't have realized that the patient is weak because of not doing dialysis. They will really become better after doing dialysis. So after the initiation of dialysis, we have 50% of the patients in whom the distress goes away. Actually, the distress goes away because volume overload symptoms are not there. They can eat well. There is no restriction on food. We actually tell them to eat more proteins. Some patients are really happy after starting dialysis. But there are a few patients after 2 or 3 years when the really the problems with vascular access or mineral bone disease sets in, where they have proximal muscle weakness or bony pains or fractures or inability to walk around is when the distress can happen. So in that situation, yes, we try to mitigate that. kind of our spirits have to be kept high to give the emotional support to the patient. So that's
So dialysis actually can help dialyze distress. So distress is also dialysable if you
yes,
do it in the
yes.
right way.
Very true, sir. It's only in the beginning of dialysis where the patient has a negative feeling about dialysis. Once they see many patients on dialysis doing well and they themselves becoming better, they're able to sleep comfortably and they're able to eat everything, that's when their confidence also builds up. But to make them realize that that is what the next step it's a challenge to us. So actually, I can quote here, usually our guidelines recommend that once the GFR drops to around 15, and we have to create AV fistula so that the dialysis can be initiated. So but it is very difficult to convince the patients to go for the AV fistula even before initiation of dialysis. So our HOD used to tell that any student who would convince the patient to get an AV fistula before actually we initiate the dialysis, that student deserves a pass mark because he has convinced the patient to the maximum extent. He is the best one. So to enable this is a little challenge.
So now we are coming to solution statements. We realize the
Yes.
problem. Emotions can be a strength for us. They can be joyous, but they can also be a challenge for us, not only for the patient, but for us as well. So these are problem statements. But now we are moving to solution that we have identified that this is a challenge. Now, the problem with our training is that we are all very well trained in the biomedical aspects of medicine. So let us say you read Hutchison or you read Harrison, that tells you how to go about diagnosing a particular disease, and then it tells you about how to treat. But when it comes to psychosocial aspects, motivational therapeutics, then we are not trained formally. For example, we would know 20 types of theories for the pathogenesis of cancer or fatty liver, but we don't know even a single theory for the motivation, for the theories of motivation. So, but let's come to solutions today in our 4D program, and let's break our subject down into small bits and pieces. Let's structure it so that we can understand. So, Dr. Manohar, when a patient walks to you, one style of triage is phenotyping. You phenotype a patient the moment the diabetic patient walks in. Some patients will be catabolic, others may be eubolic, except for the glucose, and others may be anabolic, maladaptive anabolic. This is phenotype. But let's do a sapiotyping. Sapio means intelligence, sapiens. So there are, based on your experience in Bangalore, there are some people who are literate, numerate, and they accept therapy. Like Dr. Anusha said, the elder people will accept that they got an MI. They will accept the treatment also, a primary PTCA, more quickly. So some are educated, literate, numerate, and accepting. There are others who are illiterate, innumerate, but they are willing to learn. So when you talk to them, they say, yes, doc, I understood what you said. There are others who are malnumerate, malliterate. They feel that they are literate or numerate, but they have read the wrong book. Instead of reading maybe Harrison, they end up reading some treatise by Avicenna, 1,000 years old. And so in your OPD, could you give us a rough distribution?
It's a very difficult question. I think we should do one analysis of this. We should do a study on it. How many people are already decided a treatment and come? I can give an example. My own classmate, my high school classmate, she is numerically BMI is just around 21, 22, and she wants to take the weight loss drug. And she says she has a link with one of the hospitals in which one of these colleagues are studying, working, but she didn't want to, I also don't want to quote. So she said, now everyone has refused, you give it to me. I told then, means she's adamant, she's very literate and very conscious about herself, how she should look and so on. So prescribe me Munjaro. So that discussion went very, very long. But just now I had another patient who required it. They were very hesitant for the treatment of obesity part of it. She had snoring, knee pains, and borderline IGT level of glucose. I'm very, very glad now she has lost 10 kgs in 10 weeks. And she came for a dose escalation, and she had not agreed for a sleep study in the first place, but she says her snoring has just disappeared. So I think one size won't fit all, definitely, but I think it is better for us to sit in their shoes and think for a while. You don't have to mock my friend who thought that even though she is just about normal weight itself in BMI, and she still wants an injection to lose weight because she wants to see her cheekbone, it seems. That's why she wants to take the injection. So I think we should sometimes sit in their shoes also. The time constraint is always there for all of us, and then make judgments with respect to where they classify, and try to, again, at the end of the day, put our technically correct foot forward initially, legally, technically, what is forward, and then explain. And always previously it used to be doctor's orders. Now I don't think there is any order there. Everyone is literate. So we only discuss and suggest the treatment. So I think by doing this, many people will still come towards our side of why insulin is needed, or why stenting is needed, or why dialysis is needed, rather than just writing, "Oh, you start on insulin or start on dialysis." That extra bit of time, empathy, we should develop.
So let us try to paraphrase and summarize what Dr. Manohar has said. First of all, one size will not fit all. You need different biomedical and also different psychosocial strategies for each patient. Even in a single patient, there will also be intra-individual variation. Today the patient is grumpy and grouchy, different approach. Tomorrow the patient is in a good mood, different approach. That's one aspect. The second aspect is, in general, what I would say, begin your statement with a yes and with a yes. In between, you do whatever you want. Let us say a patient says, I am in decay, but I want tablets. Yes, I understand that you want tablets. Even I would do the same if I were in your place. However, such and such is the reality. And yes, we can give you tablets, but that will harm you. We don't want to harm you. And all of us should be aware, trying to commit suicide in India, that is 1 year of penalty in jail. But abetment to suicide, that is 10 years of jail. So, I mean, none of us would want to do that. Similarly, for this lady with that BMI of 21, so yes, madam, I understand. There may be an indication. For example, normal weight obesity. You might have high levels of fat percentage. We understand that. Perhaps you would like to get a DEXA done before we initiate. Or perhaps you might want a finite trial. But in case you get GI side effects, then you must stop. And also, madam, do remember that you will have to buy 4 injections together. And you might end up wasting 3 injections because you decide to change your mood after the first dose. So, madam, just think about it and come back next time. So, this is a finite request. So, madam, why don't you think about it? You throw the ball back in her court. You've not said no to her. Your beginning was, yes, we can give you. Yes, there can be indications. And why don't you think about it and come back? So, that would be a softer way. To put all this together, in Dr. Anusha, in endocrinology, we have this concept of social pharmacology. So that is I for inform, I for incubate, I for initiate. So that is what I did just now. We informed the patient about the indications, contraindications, the caveats, concerns, and the side effects of tirzepatide. Inform. You let the idea incubate in her mind. And when she comes back next time, then you start. But do you have this luxury in cardiology, ma'am? Inform, incubate. How long will the idea incubate in somebody who has got unstable angina or acute coronary syndrome?
Yes. Yes, sir. In a myocardial infarction, we have to actually scare them. There's no other go, because that is actually scary. And the thing is here
Maybe
that
they have to say intubate. If you don't, if you don't have to go through those 3, you might have to intubate.
yeah, because and to my surprise, one of the senior physicians was my teacher. When he had MI, he was practicing medicine for the last 40 years. He's in 70s now. And he denied angioplasty for 7 hours, in spite of he himself witnessing an ECG ST elevation in the anterior leads. So that is the kind of resistance people throw around. The thing is, yeah, in our case, most of the times we usually tell them that it is something which is very essential, or else death could be the consequence of not getting a MI. So we just have to tell them the importance of making a timely decision at that point of time, and also tell them that there is no other choice available at all. Here we know that it is something life-saving and it is an emergency. It is urgently, it has to be done urgently. And at those times, when especially when we have what we have is, we can definitely buy 5-10 minutes. What I usually do is, I sit with the patient's relative, and I first of all give them the news that the patient has such a such disease and it has to be done. And I tell them that not to worry, just a simple touch like holding their hands or something, making them sit, offering them some water, and then discussing with them that this is what has happened, and briefly and make them understand what the physiology, and then tell them that this is important because, and tell them the reasons why. One could be a VT ending up in death, or a heart failure, permanent heart failure, or sudden cardiac death itself, or pulmonary edema, which can scar them for life. So most of the times, people do understand this. And and somebody who is very much read as like a doctor would dispute, but in most 90% of the case, 99% of the cases, people in MI, because they are suffering and they come with chest pain, they would have already realized the importance of treatment then. So their suffering itself drives treatment in such cases.
And some suggestions are it is very difficult for the person in the ICU or ICCU to remain emotionally neutral in the ICCU or emergency, to remain emotionally neutral, but you try to do that. Whatever you are saying, you say all that, but in the same tone that Dr. Anusha madam is using. Don't get angry, don't get argumentative yourself, and certainly do not be judgmental or sarcastic. And every second sentence, yes sir, I understand. I were you, I would also think the same. But you see, now we have only 33 minutes left of the golden hour. The golden hour, they must have coined that term for some golden reason. So this is one way. Another way of explaining to them is, like in decay, what we tell, or when we have patients with high glucose or ketone. So I come from Haryana, which is a sugarcane growing belt. So we say the glucose comes from the sugarcane, alcohol also comes from sugarcane. So that is how we explain ketones. Now that the ketones are high, they are working like alcohol in your brain, so you may not be able to make the right judgment. So test me, and we can discuss this later on. Similarly, for somebody with an impending MI or who is going through an MI, see, there is hypoxia. Less oxygen is reaching your brain. Why are you confused? Because your cognitive circuitry is getting starved of oxygen. So the moment we give oxygen to it, it will become better. So I understand that you are confused, but the treatment is oxygen, and you will get oxygen only if we open up your coronary arteries for you. And this concept of talking about other aspects, maybe death would be something too scary, but atrial fibrillation, pulmonary edema, heart failure, these are things that we can talk about. If the patient has had an echo done in the past, then they know what ejection fraction is. Most patients are aware of that. That number is the easiest to explain. And yet another way to talk to a person who is in an acute coronary syndrome would to say that we want to keep your heart young, we want to keep it healthy. And here what we use is, because many of our patients have migrated to the US or to Canada, then we say we are going to put an American stent. So see, you were never able to get a visa for USA, but we'll give you an American heart now, and suddenly you will feel better. If the patient is of my age, my gender, then I might add in a little bit of joke as well. See, once you get an American heart, you might get an American friend as well. So let's look forward to a foster future. So these are the ways in which you talk about it. Dr. Pooja, one concept I learned from a colleague in New Delhi. So he has the same that Dr. Manohar had. That we are not able to convince the patient to take insulin or tirzepatide. Now it's tirzepatide, semaglutide. So he began adding, yeah, madam, of course you can take tirzepatide, semaglutide. But if you don't want to take, I can refer you to such and such person. He's a bariatric surgeon. So our medicine is going to cost 15,000 per month, which is something like 1.5 lakhs per year. And the bariatric surgeon, he will take only 6 lakhs. If you want to get robotic surgery done, only 10 lakhs, madam. So he's up. So they kind of, change the framework or that benchmark for thinking. Someone who was thinking that 50,000 rupees is too expensive, suddenly he feels that this is so cheap as compared to bariatric surgery. So ma'am, in nephrology also, you use this sometimes, like renal replacement therapy given earlier on is more economical than what you would have to do if you get complications. So do you use this financial kind of explanation?
Definitely, sir. Yes, sir. Because as I told earlier, we kind of prime the patients when their creatinine starts slowly inching up, and we know that in a few months this is going to reach a state which the patients have not witnessed. They feel they're all fine. Creatinine 6, fine. Creatinine 7, fine. 8, okay. So they feel just that the number is a little high, but I am fine. So they don't realize the importance of spending a little early on the AV fistula, which we call it as stepney. So कार के बाजू में stepney है. So it is only that we use. So it's just like a stepney. We'll just keep it for you so that you need not have an issue further, because we tell them in case they land up in the dialysis situation as an emergency, then it will be no time to incubate, sir, only intubate. So they will, so there's no incubation time at that point of time. It will only be intubation, ventilation, ICU, all the ICU spending extras have 5-6 lakhs that goes. So this is how, as you told, sir, we kind of prime them, but we don't scare them. It is 1 or 2 settings when they don't agree. We also do not want to have a very unhappy ending of our OPD consultation. We also want to make them feel that it was a worthwhile consultation in an OPD. So we also do not sometimes indulge in telling them, yes, you will require dialysis or so, or a transplantation. But then as a matter of fact, in case they are too adamant, even with a creatinine of 10, we have seen patients coming with creat 25 and they still disagree. At that point of time, we may have to scare them a bit, but in a very polite way. Yes, sir. So coming to the renal transplantation, yes, definitely we give them the option, especially youngsters who are in their, say, 25, 30s. The quality of life on renal transplantation is definitely better than the quality of life on dialysis, because the dialysis expenditure at the end of 3 or 4 years will be the same as that of having a transplant done. So definitely we do counsel them in this way that nowadays there is a lot of funds also available, like CM fund, PM fund, and a few of them have ESI and insurance. So it definitely works out well. So yes, sir, as you stated, this kind of step-up approach and a little bit of information has to be chewed and digested by us to for them to assimilate. They will not do the chewing and digesting job. So they'll have to be rightly given in that assimilatable form.
So, Dr. Manohar, this Manohar model of incubation versus intubation seems to be very nice. And what Dr. Pooja has said, everything doesn't have to be given as one bolus. So the Latin word is holus bolus, the entire whole given in one bolus. You can always go stepwise. Dr. Manohar, let's look at 3 Ds, and all of us practice in family-oriented, community-oriented setups. All of us in India, we are family-oriented and community-oriented. So 3 Ds now, and just think of patients who came to your OPD today or maybe last week and see how it worked for you. D is for the duration of a relationship with that particular patient, or his or her family, or his or her community, especially if they are from an ethnic minority, an ethnic group that is different from yours. The duration of relationship you have had in the OPD with that group. D is also for depth of relationship. Are you treating only that person, or perhaps you have treated his father as well, maybe his grandfather, maybe his aunt or his nephew. So that is depth or width. And the third D is degree of distress. The patient has come to you with lots of symptoms of maybe a glucose of 201, and on the other hand, there may be a patient who is asymptomatic even with the glucose of 600. So 3 Ds. How does this define your speed of priming? So let us say our final aim is to get the patient to take insulin or a GLP-1 receptor analog. These 3 Ds, and can you think maybe of any counseling mistake that you made, or maybe any counseling achievement that you experienced last week?
Just yesterday, I worked for one other company as their medical director. I know this boy from about 8 years. His father had come with 530 sugar. And I asked him, when was the last you checked the sugar? You just checked it now, and when was the last he checked? He said 3 months back and it was still 500. So, and they wanted to travel somewhere. And I took a lot of time. I actually thought your duration and depth was quite a lot with him.
Yeah.
I even used to come home to fix up some of my software stuff. So I know his family also so very well. But I was shocked at the end of the day, with all my time spent on counseling, he said, I'm not going to take insulin. So because possibly he thought, of course, he has lost weight, but he has no other symptom, as Dr. Pooja was mentioning. I'm fine whether creatinine is 25 or sugar is 550. Maybe Dr. Anusha is a bit more lucky, or because acutely they're trying to, if symptoms is there, then they will definitely accept our thing. So yeah, I got your point, sir. Duration and depth matter, but it didn't matter yesterday. Again, individualization is the key, but that's a great approach. No wonder I'm one of the biggest fans of you. The way you put things across and write your review articles is amazing. So I like this and I adopt this further.
Yeah. Here what happens is we talked of two typings. One is the phenotype. So we see here that this is the person who is at risk of a lot of complications. The other one was the sapiotype. We've realized that he is literate, numerate, but mal-literate, mal-numerate. The third one is the psyche typing. Here he is in apathy. He is apathetic. He's just not bothered. So if you are going to, neither was Rome built in a day, nor was Ayodhya. If you feel that in one day we are going to achieve everything, it's not going to work. So you just go stepwise. So then, okay, you want to travel, let me just give you an insurance. Maybe, something like DPP-4 inhibitor plus metformin, which is not going to get the 530 glucose down, but it is better than nothing. So let me just give you an insurance for your pancreas. And that is a scientifically correct statement. Okay, while at it, is it okay if I give you an insurance for your heart as well? So you might add the statin if it is indicated. And then when you come back, let's talk about things. You will certainly feel much better. And then how many times do you have to get up at night to go to the bathroom? Okay, that will change. Instead of getting up at 1 a.m., now you might get up at 3 a.m. So at least just you begin. And just remember that Ayodhya was not built in a day. So this person is also not going to get treated in 3 days, but you give him something.
Absolutely. Something similar I have done it.
Yeah.
Thank you, sir.
Yes. And many times, this is speaking to all our colleagues across the country. You find a prescription by someone, maybe by myself, by Dr. Manohar, and you laugh, Doctor Saab didn't even know that we have to give insulin, we have to give basal bolus. Now, everything cannot be documented. How do you document each and everything that you were talking about to the patient? I may have lost the war. Dr. Manohar may have lost the war. He was not able to prescribe insulin, but at least he won the battle. And like Dr. Pooja said, you want the consultation to end on a happy note. At least you lose the battle. At least the patient comes back for the next battle and then you win next time. Yeah.
Yes, that is true, sir. That is very true. Because if we tell them, because we see the number is 10.2, urea 200, patient is comfortable, he is walking around. So he is definitely not ready for anything called dialysis. He is just not ready. So at that point of time, if we break him this bad news, so it is a little tricky for him. So we have to get into their shoes. We have to take that into account. Make them feel confident about our decision. So that's how we kind of step up.
Dr. Anusha, there is this term known as Takotsubo cardiomyopathy. In endocrinology, we call it Takotsubo endocrinopathy because we feel it is mediated by endocrine chemicals. So what Dr. Pooja said, breaking the bad news, is it possible that Dr. Manohar, Dr. Pooja, myself, we may end up causing iatrogenic cardiac disease in the OPD if we don't handle emotions properly? Ma'am, can you describe the disease for us first, what Takotsubo means, and then let's see about how we can prevent such iatrogenic issues in our metabolic clinics.
So no, sir, don't be afraid that breaking such wouldn't cause Takotsubo. So Takotsubo, the other ways in a layman's term, we call it broken heart syndrome. So what happens is something which is really impending doom kind. So the news have to be really heartbreaking, like loss of kin or some loss of a spouse, something like that, something which just changes life forever. So these are the things which usually trigger. And what happens is when something like that happens, there is a surge of catecholamines in the body, which directly affect the beta receptors in the heart, and they are overwhelmed, and which leads to myocardial dysfunction, which we call a certain part of the heart is particularly involved. So we call it as apical ballooning syndrome, but it is reversible. And another condition is that they cannot have a coronary artery disease superimposed on broken heart. So many a times we do angiogram because we have to rule out a heart failure occurring because of ischemia, and the angiogram by definition has to be normal. So these news of breaking bad news about health shouldn't usually cause broken hearts or surgical stress. Many times we are discussing. I also wanted to make a note, make a point about patients with hypertension. Most of the times in our clinics, we see patients coming with hypertension, and many times they will be hypertensive and they know that they have hypertension, but they do not. But one common question which always comes from the other side is, once we start BP tablet, we have to continue it for life. So the next question I ask them is usually, so you weigh being hypertensive and not taking medication, and taking medication for 2 to 3 decades or even for till death. So what do you think will happen between these two patients? A person who's not taking medication and a person who's living with hypertension, who's taking it. So then I tell them that people who have taken medications till death, nothing has actually happened to them. Their lifespans have been normal. But people who do not take medications, they slowly start having kidney problems, heart problems, eye problems, strokes, and they will end up in dialysis. I tell them that this could be the ultimate effect of not taking. Yeah, I scare them because I really think I'm afraid for them, but I want them to realize the importance. And recently, I had a young patient, 28-year-old. He tells his blood pressure when I checked in the clinic was 180 by 110 or something. So when I asked him what happened, is he hypertensive? He said he's hypertensive. And why don't you take medication? No, madam. What if I have to take medication regularly? Then my blood pressure was fine, but I was in alcohol withdrawal. That's why my pressure has increased. What? Like, you are not scared of swimming, drowning in the alcohol. You do not know what alcohol is doing to your body, but you're scared of taking medications, which is only going to protect you. So these are the kind of extremes of people which come across. And again, the same luck, the same trick, and most of the times it does work. When I tell them kidney dialysis, heart attack, strokes, and I also tell them that it can paralyze and this make you bedridden, and you will have to seek help for even attending your nature calls. That's something which I try to show them what could happen, the extremes. And most of the times patients do understand that it is important.
We use the word metabolic karma. So just like you have glycemic memory, metabolic legacy, metabolic memory, metabolic karma, kidney karma, cardio karma will encapsulate all this. So if you do the right karma for your cardiac muscle or for your kidney, both left and right, Dr. Pooja madam. So if you do the right karma, you will enjoy the right karma, which is good health. Dr. Manohar, we have a comment from KMC Mangalore, and what they say is that from 1993 or 1928, there was an epidemic of Takotsubo cardiomyopathy in the girls' hostel. Do you know the etiology of that, Dr. Manohar?
I couldn't hear. 1993, where was the...
In KMC Mangalore.
I don't think so. I don't know. I don't think it happened, but...
So, but there's a comment coming from KMC Mangalore, and the point is, but like Dr. Anusha said, you don't have to worry too much, and it would have been reversible, all that apical ballooning.
Seriously, I'm not... I won't think any of the KMC would be listening to me anyway.
See, the comment came only for you, so it didn't come from JSS Mysore or anywhere else. But Dr. Pooja, now we use the word metabolic karma. Now this may appeal to relatively elder people, more spiritual people, but look at Bangalore city, IT hub. So do you ever use analogies from computer science, from information technology to tell your patient to kind of clean up their computer or their RAM all that creatinine and urea is harming the speed of their computer. Do you ever use analogies from your patients'
Yes, sir.
professional life?
So, sir, most of the patients that I encounter are partly semi-urban to rural setups, sir. So what I tell them is, I give them the example of a kitchen. See, in kitchen, whenever you're preparing something, definitely there will be waste products that will get accumulated. So any recipe will not be without the dustbin being full. Now, which is the dustbin here? The kidney is the dustbin. So if you don't periodically clean up your dustbin, your house will rot. Your kitchen will smell badly. So unfortunately, kitchen is not being cleaned. That means the dustbin is not doing its job well. So that's how the kidney is not doing its job well. So what will happen to the body? The body will also suffer. I also tell them, madam, if we start dialysis, like there are certain situations, it is like AKI on CKD, where we may have to temporarily put them on dialysis. Once we start dialysis, this dialysis is going to be permanent. That is their fear. So as Madam Anusha told, there is a hesitancy, but I tell them, see, madam, whenever mother is not well at home, it is the daughter who does the job. Once the mother gets better, then daughter will give up and mother will start continuing the job. Similarly, when the kidney is not well, the dialysis machine will do the job. Once the kidney gets better, the machine will stop. Just by doing dialysis, it will not prevent the kidney from getting better or not getting better. So this analogy, when I tell them, they kind of understand that yes, so machine is not taking over the kidney function, rather helping the whole family. See, I also tell them, see, now your mother is not well. So in the family, if one person is not well, every other person in the family is also feeling bad and not very happy. Like that, if the kidney is not well, every other person in the body family is also not very happy. Your heart, your lungs, your liver is not happy. So might as well do the kidney job by using a machine and keep the family happy. So then they try to understand and give consent. So I've not used the computer part of it, sir, but I've used the local part of it.
I also work in a rural, semi-urban, small urban setup, and my analogies are usually related to farming and to food. And suddenly, speaking of food, that also brings positive emotions. So, Dr. Manohar, what is your favorite food?
Difficult question. Everything is favorite. Whatever my mom or my wife makes. I prefer typically South Indian food. Generally, the ragi roti, jola roti, what we have. Desserts, yes, but less often. But I do still indulge.
And Dr. Nusha, madam, your favorite food?
So biryani, but I'm a very big foodie. I eat everything.
Me too. So that's why we all get along well together. And for those of us who live with diabetes or obesity, and for our patients as well, you eat, but then you just walk a couple of thousand steps extra and you do a little bit of exercise more. So, Dr. Nusha, madam, do you use food-based analogies or maybe computer-based analogies in your OPD to explain to patient what is happening?
So we have mostly those things which MRs give us, which has picture, which has six. So I use those pictures to and make them understand, and they are very much informative. And people, when it is stenting and all, when we have the models where the stent is put, when we have those heart models, artery models, and all, that comes very handy while explaining, and usually it solves all their doubts. Analogy is not much used actually.
So, but information is what seems to be the key message that is coming out from our experts, and you inform in different ways. If person is from a village, you will use different style. If person is spiritual, then metabolic karma, kidney karma is perfect. For someone else, it might be kitchen based, and for someone it might be computer. But Dr. Manohar, your patients are more from the IT industry, is that right?
Yeah, more sort of IT industry, and also other type also is there, but more into the so-called very literate types.
So if we take high glucose or high creatinine or maybe high potassium as being like a bad AQI, air quality index, so that is some method that we use. See, your glucose level is so high, that is like a bad AQI, and it is going to impact each and every organ of the body. Dr. Pooja also highlighted that the kidneys are not isolated organs. They will impact each and every system of your health. So can we use computer analogy and talk about RAM, cleaning up the RAM, the speed of computer? Have you tried that, or maybe you would like to try tomorrow when you go to the clinic now?
Yeah, I think I'll tomorrow. With all the
So actually-
CGMs coming, I have shown many times how ragi can be very deceptive. I have my own CGM data, even though I'm a glycemic, how ragi kicks up the sugar and things like that. So it is not what you eat, how much you eat, how you eat, when you eat. Going by Dr. Anusha, like the way to a man's heart and heart attack is through the gut anyway. So food can make you or break you.
Madam wanted to add
That's
something.
Because
Madam.
yes, definitely, sir. As Dr. Manohar told, they will insist that they have always been on ragi and it's kind of a very good diet. So how could they even land up in this problem? That is their question. So it doesn't gel well with the food. Yeah.
Dr. Anusha, madam?
So I am an avid reader. Read in the sense not really reader, but I go through reels where I think once you watch a reel, you have 100 reels which are ready to be sent to our computers. So I read a lot about nutrition. And I realized there's one one Glucose Revolution channel which I subscribed to, and she had very good knowledge, and she puts up very nice things how to eat and all, especially for diabetes. So I tell my patients who are receptive to it the channel name and tell them to read on their own and increase their knowledge, because I think nutrition is not not a very simple thing which can be just done in a day. I'm still learning as a doctor, and there's more to learn. So once a person digs more and more deeper into it, they will become more informative, and they'll gather more information, and that changes their behavior, self-directed. So I think it helps.
So this information, this learning is a journey. It's not a one-end kind of a thing. It's an infinite game. And there is a book also, The Infinite Game by Simon Sinek. And that tells us you just continue working and you follow your purpose, your passion. We've been discussing for so long, Dr. Manohar. It's festive season. We didn't even realize the time. But let's try to conclude and put everything together. Our work was to talk about navigating the various emotions. So would you like to put everything together for us? How do we navigate emotions? Maybe, sir, if you could focus on your own emotions, our emotions as healthcare professionals, how do we navigate those?
Yeah, the basis as I started is the psyche and soma are inseparable. One begets other. And try to put yourself in the patient's position also sometimes when they are in denial mode, or we all describe different situations. Sometimes our own colleagues' unwillingness to go in for the procedure which he would have done hundreds of them in his lifetime also is still baffling me. But I don't know what reasons they had. And as you rightly pointed out, sir, the 3Ds and the pheno and the sapiotypes should be running through our mind. And I like what Dr. Pooja said, that try to end the conversation on a happy note. Everyone likes an happy ending, whichever way, so that we can continue forward rather than abandoning a person who is not listened to us. We need to give importance to their mind and their thought process. And you rightly pointed it out also. It could vary within a day or within the week, where the same person can interpret things differently. And if we are trying to do, in our best of knowledge, trying to do primum non nocere to the patients, I think we have done our job. Yeah, and it also, we need to look back on a holiday 9 o'clock plus, and then we are still not upstairs in the house, or some of you are still on glued, even though your house is always a difficult thing.
Take care of your own health and just be relaxed and enjoy your job as you go through it.
Yes.
Nusha, madam, sometimes we have, like hyper kind of patients who are hyper argumentative, hyper irritated, hyper everything. How do you calm them down? Does it come from the heart or does it come from the head, this calming down?
It comes from the head. It's the mind which directs the emotions, I feel. I think it's their atmosphere at home, their upbringing, the parental effects. I think it has multitude of reasons for them to be hyper anxious. sometimes after a catastrophic event, after a major event befalling on them, they start the self-doubting, and they ask each other, can I climb 2 stairs at a time? Can I eat that? Can I eat this? Can I travel? Can I mean, sometimes their doubts are so trivial. They will be doing it, but they'll come and ask, I'm doing this, is it okay? So at those times, I think it's where, yeah, it for us at the job would be to just sit them down, answer all their queries, and tell them that it's not that they will, and they even think that, can I sleep on the left side, like, because there is a stent on the left side. Okay, yeah, so trivial as that. So then we tell them that the stent, and then we go into the biology of it, tell them how it gets endothelialized and get exteriorized from the body, and then nothing, no physical movement will ever shake the stent. And then we go and address each of their activities, each of their doubts, and once they are fully confident, until they have all the doubts solved, be patient with them. I think it's very important for us to just be patient and answer all the questions than ignoring or just shoving them, look, everything is fine. No, that's not we just answer.
The keywords are patience and perseverance. Thank you for that, madam. In general, if someone displays anger or irritability in the OPD, do not respond with anger or irritability. Though I myself get angry in the OPD sometimes. So anger multiplied by anger is going to become anger squared. Today I made a mistake in the OPD. This fellow, and he was perhaps 1 or 2 years elder to me. So he came and I am going to die, this and that. I am taking your medicine for so long, my glucose is not normal. The reason was that we have advised insulin 2 years ago. He has never listened. Each time he comes, he says, I stopped my medicine 2 days ago. So I was trying to tell him very politely that, see, if you're climbing the mountain and you stop in the middle, you're going to slide back. That is what happens with your car, with your vehicle. He was not in a mood to listen. I also lost my temper. Then how I did the mid-course correction, then I told him, see, I am 5 years elder to you, which was a lie. And if you are ever going to talk about old age, I will come home and slap you. I told in front of his son. But that is socially acceptable in my culture, telling a younger brother that I will scold. So I was able to conclude on a happy ending. I brought the patient's son into the picture. And I said, now see, I am elder to both of you. And if your father ever says anything about old age or dying because of diabetes, I am going to come home and scold him. So he has to take his medicine, he has to remain young. But that it was a total mistake that I was making. Anger multiplied by anger square. But then I did mid-course correction and came out of it fairly well. So the patient will come back to me. So these are things we should be aware of. Yeah. Sometimes we do get tired and disappointed in the OPD. So Dr. Pooja, I learned a concept called glossopalatal maneuver. And the nice thing is the spelling of maneuver, it's different in British English, different in American English, and different in Haryanvi English. In Haryanvi English, we have 12 types of spelling for maneuver. But it still works. Glossopalatal maneuver means you take the tip of your tongue, you press it on the palate. So let's all try that. Glossopalatal maneuver is in Latin. It actually comes from the Upanishads, from Maitri Upanishad, book 6, verse 20. And in Maitri Upanishad, the author promises that if you keep on practicing this glossopalatal maneuver, you will attain Brahman. It's a method of meditation. But ma'am, question coming from the audience to you is, when will our moderator practice glossopalatal maneuver so that we can finish the webinar today?
No, sir. It is actually a very engaging webinar. It's a very, very important topic because as a medical student, there should be there are so many doctors who learn it in very scientific way, but combining psychological, emotional things to reach out to the patient is a different ball game, which decides whether you are a good doctor, better doctor, or a best doctor. So each patient, when we are judging the patient, at the same time, patient will be judging us. So it is always a dual thing that is happening, and we shouldn't just hear, we should listen. So there is a difference between hearing and listening to what patient tells. So that's what I have understood all the way through this, that they need only part of our treatment in the form of medicine to make them feel better. And rest of the stuff is talking and counseling, especially medical field. Surgical aspect is totally different. But we in the medical field, okay, we do some interventions and all that, but most of it, because our patients do keep coming back, we have to be definitely more patient. For that patience to develop, we should have had our EQ to the to the power of 1,000, or our patience to the power of 1,000. We should be spiritually happy to make them feel happy. So our focus has to be to build in our pots first, to just lend out some water to them. So that takes actually a long way. It will never happen in a day. Especially the MBBS graduates who are coming out now, they are preparing for the next exam. When they are out of the MD, they are again preparing for the next exam. So never, they will always feel that on-job learning is one thing, because they should feel that they are my patients to treat with. Even as a MBBS intern or a postgraduate, they should always feel that this is my patient. It's only then that they'll be doing a full justice to the patient. Otherwise, it is like the consultant will come, she will take the decision. We are only going to put the notes. That is not going to work. So even on an OPD practice, they have to inculcate that.
To learn from the very beginning, from day one. But it's been great being with everyone. Dr. Manohar, thank you so much. Dr. Krishna Madam, thank you. Dr. Pooja Madam, thank you for being with us.
Thank you.
This is detailed and diabetes, detailed discussion and dialogue in diabetes and Indian diabetes. And you see that we've been able to bring out the best of our best experts, and what they say will actually make a difference to our OPD tomorrow and to the entire journey of life for us as persons, as professionals. Once again, thanks is a very small word, Dr. Manor, Dr. Nusha, Dr. Pooja. The most beautiful language for saying thank you is Haryanvi. We do not have a word for thank you. We have to take loan words from Punjabi or Hindi or Urdu. So the concept of thank you doesn't exist in the state. So the closest that we is a phrase called thara, that means aapka or your, bhala ho, thara bhala ho, which means may good be to you. And the answer to that is sabka, make it be good for all. On this optimistic note, and we've all managed to learn some Haryanvi as well. So sabka bhala. Jai Hind.
Thank you so very much, sir. It was
Yes, sir.
Thank you. Goodbye, everyone.